Hi, everyone. My name is Dr. Emily Samuels. I am a geriatrician at Mount Sinai in an outpatient clinic. Today's lecture is meant to go over wound care. It won't go in depth about the topicals or dressing options because that would take a whole lecture itself, but this will go over general things that may come up in board review or things that you come into contact with while you are in the clinic. I have no disclosures. We are going to today review basic wound care principles. We will go over anatomy and wound healing, the classification and types of wounds, how to assess a wound and how to document it, and then briefly go over some types of wound management, most importantly, the support surfaces that you could order for your patient, how to clean, briefly how to debride, and then one topical consideration to leave you with. So first and most important is the anatomy of the skin. The outermost layer of the skin is the epidermis. What you should know about the epidermis is it is important as a barrier to protect yourself from the outside world, as well as to maintain the moisture within your skin. It is avascular and it regenerates every 4 weeks. This is important to know because with a wound, if it is well taken care of, it should take approximately 4 weeks to fully heal. The next layer down is the dermis. This is the bulk of the skin. It is the first vascular layer, and it's the workhorse of wound healing is a cell called a fibroblast. These are the main connective tissue cells, and they are in charge of making the two major proteins, collagen and elastin. Below the dermis is the subcutaneous tissue. That is composed mostly of fat tissue. It's also vascular. It's important for insulation and cushion. Below that, so between the subcutaneous tissue and the muscle, is the fascia. This is a very dense connective tissue layer that helps to separate the subcutaneous tissue from the muscle. The muscle is of anything in the body, the tissue that has the greatest demand for oxygen and therefore is the most sensitive to ischemia. So all of these layers together, we will discuss how they play a role in wound healing. Wound healing progresses or should progress through 4 phases. The first of which is hemostasis. This is something that has to occur. It occurs immediately after injury, and it has to be accomplished for wound healing to progress to the other phases. The biggest players in hemostasis are the red blood cell and the platelet in forming a clot or a scab. Then we progress to the inflammatory phase, where the biggest players are the neutrophil that comes first, followed by the macrophage. The neutrophil starts releasing these pro-inflammatory cytokines, these proteins that say that there is inflammation or should be inflammation in the area. These neutrophils also help to phagocytose or absorb and kill any microbes that are in the area. And when these neutrophils are done doing their business, the macrophage comes along and eats up the neutrophils. And they're originally pro-inflammatory, but as the phase goes on, they become pro-healing macrophages. And they start to release growth factors that attract other healing cells that stimulate this proliferative phase that comes next. The proliferative phase has 4 different important characteristics. So one of which is the extracellular matrix production. So that collagen, that elastin, all made by the fibroblasts, as well as angiogenesis. So as I mentioned, the subcutaneous tissue, the dermis, they are vascular layers. And when these tissues are interrupted, you need to make new blood vessels. And so this happens in the proliferative phase. The combination of the collagen and elastin, extracellular matrix, as well as angiogenesis is what forms something called granulation tissue. That is the healthy tissue that you see. It's pink or red, and that is a healthy wound. The other 2 things that have to happen in the proliferative phase are wound contraction and epithelialization. So there is a cell called the myofibroblast, myo in the prefix, meaning muscle. So these are specialized fibroblasts that can actually control the contraction of the skin. And depending on the layer of your skin, it depends on how lax you are. So if there is skin overlaying the buttocks, that skin is very lax and easier to contract versus the skin overlying the shin, which is much more taut. On average, though, you should expect with healthy healing approximately 0.5 centimeter of wound contraction over 1 week of time. After that, epithelialization happens and your skin is closed. Although the skin is closed, you are far from having a healed wound. Then you enter the remodeling phase. There was this hectic inflammatory phase and proliferative phase where the fibroblasts were busy laying down collagen fibers. So they laid down collagen 3. And in this remodeling phase, now that things are closed and they have time to remodel, they start to make this organized collagen type 1, which is stronger and better organized. Over time, the scar that you form starts to gain strength. So as I said, even though you are re-epithelialized, that does not mean that your wound is done. After 1 week, once the skin is closed, that area of wound is only 3% strength compared to normal tissue. So if you are overseeing a caregiver, family, home health aide who is dealing with a wound and you have done a great job, the wound is healed, this does not mean that they can stop the gold standard of care, right? And that is, making sure offloading the patient, making sure that they are turned at least every 2, if not every 3 to 4 hours off of the area of pressure, and to continue keeping their eye on that area where the wound just was. 3 weeks after the wound has closed, your tissue has approximately 20% of the normal strength of tissue. And then 3 months after it has closed, you reach around 80% strength of normal tissue. So while remodeling is still going along, this is about the maximum strength that you can achieve. Each time let's say this person has already had a sacral wound a year or 2 ago, and now they have another wound opening up in the same area. Each time this happens, the wound may take longer to progress through these phases of healing, and remodeling may take longer, but that area of wound will always go back to approximately 80% of the normal strength of the tissue. Not 80% of 80% of 80%, but 80% of the normal tissue. So this illustrates the phases of normal wound healing in a different way. It really addresses the time frame that you should expect. So as I said, in a good, healthy wound bed that you have debrided and cleaned, you should expect a wound may heal in approximately 4 weeks. This breaks it down into how things may change. So hemostasis should happen in the first few hours. And then followed by the inflammatory phase that can be anywhere between 1 and 6 days. And you can see also at the top how the biggest players, these proteins, change throughout the phases. Followed by the proliferative phase, which can be anywhere up to 3 weeks. And then that more organized remodeling phase with the type 1 collagen takes up to 2 years. So that wound that you have healed, you continue to follow just to make sure that nothing reopens. Then we could talk about the classification of wounds. These are acute wounds. Those are easily identified by us, by family members, to say, what, this is a new wound, this is an acute wound. Or a chronic wound. And the definition of a chronic wound is really some kind of wound that progresses slowly through those healing phases and fails to respond to standards of care. Chronic wounds are difficult to heal because they have found themselves in a chronically inflamed state. And so you need to use mechanisms, topicals, procedures to try and promote this to go forth into the proliferative phase. Then there are surgical wounds. Now, either these were intentionally left open, so secondary intention healing, or they are wound dehiscences. And then there are traumatic wounds, depending on what the person may come in contact with. Is this truly a traumatic wound in someone who is healthy, or a traumatic wound in someone who has comorbidities? And we will talk about some of those in the coming slides. And then we will discuss the types of wounds. So the most common one that we are all quite familiar with is pressure injuries. These are the most popular ones to discuss. Then there are arterial ulcers, venous ulcers, and diabetic ulcers. And you will probably come across each type of these as you go along in your medical career. When it comes to pressure injuries, what do you want to know about your patient? There are some things that you have to know, and that will give you a clue as to why this person is developing a pressure injury. Past medical history in all wounds is very important, whether or not they have heart attacks or strokes or whatever medical things that they are undergoing is now impacting their functional status, whether it also be chemotherapy, something, recent surgery. What is their functional status? Are they independent? Are they dependent for certain things? And how do they spend their days? You may know that the person has presented to you in a wheelchair, but do they spend most of their day in a wheelchair? That brings us to the question of what kind of durable medical equipment do they use? Do they have a hospital bed at home? Do they have a wheelchair? Does this wheelchair have a specialized seat in it? Do they have a Hoyer lift at home? What kinds of things does their body come in contact on a regular basis? And then we have all that information. We want to know, is this person alone? Do they have any kind of support at home? Do they have a home health aide? Do they have a family caregiver? Do they have a friend who is helping them? Because a pressure injury should be an alarm to you to say there is some kind of opportunity for us to intervene. A healthy skin in someone who is bedbound is a testament to how well their skin is being taken care of by their caregivers. And so there are some other things to consider. Pressure, as we know, is the force that we exert upon whatever surface we are exerting it on. And that is, one of those readily known things when we think of pressure injuries. But there are two other forces that are acting on the body that we don't often talk about, and they are friction and shear. Friction is where our body is either dragged or moved across a surface, and the skin doesn't want to move with it. So, for example, when a person is being cleaned or turned in bed, there is friction of their body against the bed. And then shear is a force that's a little more difficult to understand or explain, is that when the skin is undergoing friction on the outside, then the tissues on the inside of the body are moving in the opposite direction. And that is what shear force is. It's the movement of the muscles, the subcutaneous layer of the skin, everything against the opposite direction of what friction is pulling us. And probably the best way to illustrate this is by talking about the angle of a bed. If we have someone and the angle of the bed is fully perpendicular, so they are sitting up at 90 degrees, then most of what we're experiencing is pressure downward. And then if you were to angle this bed further down, then let's say 45 degrees, and you're sitting in a bed and suddenly you start to feel that you are slipping down the angle. You not only have friction as your body rubs against the back of the angle of the bed, but shear on the inside going in the opposite direction. And so the gold standard for prevention of worsening of wounds or causing wounds due to friction or shear is to have the angle of the bed around 30 degrees. This is an important consideration, as many of our patients, especially those that are bedbound, have either congestive heart failure and require the head of the bed to be angled upward, or are an aspiration risk and also require the angle of the bed to be high. And so if they're someone who is at increased risk of wounds or has a current wound, 30 degrees is something to remember and educate the family. This little illustration shows the most common areas for pressure injuries in someone who spends most of their time in bed. The ones that we readily think about are the lower back and the buttocks, but it can also happen on the elbow, the shoulder, the back of the head, or even the ears. And then because a lot of family members are educated about turning their loved ones, you want to think about when we turn them, can these pressure injuries occur? And so that can occur on the hip or on the inner knees if we are laying on the side and there's no pillow between our knees. And always check the heels of your patient. And then less commonly thought about, but still definitely applicable to pressure injuries, are our people who spend a large time in a wheelchair. There are some people who don't have a lot of support throughout the day, but they do have support to get them out of bed. They're moved to a wheelchair and they spend maybe 12 hours of a day in the wheelchair without having moved outside of it. What you really want to think about and is unique to a wheelchair-bound patient are the ischium as well as the spine. When in our older population or some younger patients who have severe kyphosis, their spine sticks out and is the first thing to make contact with the back of a wheelchair. You also want to be mindful of the heels, as some parts of the wheelchair and some mechanisms have metal devices back there, and the back of the heels can actually be injured, even if this person is not bedbound. Understanding your patient, because some patients who are not geriatric but are younger and are still working, some patients who are wheelchair bound have to continue to work. And so let's say they're at a computer all day and they cannot offload, and yet you tell them the only way to get rid of this pressure injury is to spend time outside of the wheelchair. These kinds of circumstances can be difficult, but can only be understood by understanding the patient as a whole. The first way of discussing pressure injuries is by this very simple illustration. There is a slide following that discusses it in words and pictures. So the first stage of a pressure ulcer or pressure injury is stage 1. This is limited to the epidermis, and it is non-blanchable erythema. All of us at one point or another may have crossed our legs, and then after a time period gotten uncomfortable and uncrossed our legs, and you see that area of redness. If we pushed our thumb against it and removed our thumb, we would see that it blanches, it turns white, and that is not a pressure injury. But that's because our body sent a signal to say we should uncross our legs, this is getting uncomfortable. If we were to keep our legs there for longer, and it does not take very long, then we would turn this into a stage 1 pressure injury. Moving on to stage 2, and this is a controversial stage among the wound community. This goes through the epidermis into the dermis, and most wound specialists say that this is the category that should be reserved for things that are caused by friction or like skin tears, is the best example. Because most of the time when we see patients, it has already progressed to stage 3 if it isn't from friction or a skin tear. Stage 3 is through the hypodermis or the subcutaneous fat, but does not go to the fascia or muscle or bone. And then stage 4 is a full thickness injury all the way to fascia, tendon, muscle, bone, ligament. If you have a stage 4, you need to consider the fact that you could have concurrent infection or workup for osteomyelitis. So as promised, here are the pictures of the pressure injuries as well as a description of them. So I will review them again. So stage 1 is this non-blanchable redness that's localized usually over a bony prominence. Stage 2 is a partial thickness loss that goes into the dermis. And again, as you can see in the picture, it looks like some kind of friction. Another thing that can be included in this category is a blister that's either open or ruptured. And then the stage 3, so they consider this full tissue loss down to the subcutaneous fat, but not to bone, tendon, or muscle. And then a stage 4 also considered full thickness, meaning it goes through the epidermis and the dermis with either exposed bone, tendon, or muscle. And then there are 2 other classifications that are not technically pressure injuries, but could become pressure injuries. The first of which is this full tissue thickness loss. You see that in the picture. This is called something that's unstageable. You know it's full thickness, it has gone through the epidermis and dermis, but you can't stage it because it's either completely obscured by dead tissue or an eschar or a scab that's in the wound bed. And in this instance, you either leave it alone and wait for it to fall off, depending on the location of the body. And the other one is a deep tissue injury, or you're suspecting a deep tissue injury. This is oftentimes from pressure or shear forces, right? Because friction affects that outer layer and shear affects the inner layers. You'll see this as a deeply purple or maroon area of discoloration that you want to follow, because while some of these may heal completely from the inside, a lot of these will open up and either be a stage 3 or stage 4, depending. Now, when you are seeing all of these stage 1, stage 2, whatever it is, when you see it and it is a stage 3 and you are treating it and it is healing and they come back and it has gotten much better, they're forming some dermis, you do not now say that this is a stage 2. Something that was a stage 3 is always a stage 3, because as we discussed in the wound healing, that entire tissue all the way down to where it started from is not the same strength as what it was before. And so it remains exactly a stage 3. You would say a healing stage 3 or a healing stage 4 or a healed stage 4, but it remains the same name. So we will start talking about the other types of ulcers, and this first one is an arterial ulcer. Arterial ulcers are associated with peripheral arterial disease. And now the two biggest risk factors for peripheral arterial disease are smoking and diabetes. Two instances where you as a provider could have some kind of intervention in terms of education with smoking cessation or in diabetic management. When you see an arterial ulcer, you kind of think it's an arterial ulcer because of a few things. One, they're often quite painful to the extent that sometimes opioids are necessary because they are from ischemia or lack of oxygen, and ischemia hurts. These arterial ulcers are often punched out and well demarcated because they are from a lack of blood supply. Because there are arterial ulcers that should be, the arteries are supplying oxygen. If for whatever reason there's a lack of oxygen to a part of the tissue, then all of the capillaries from that arteriole are all blocked off and they form this well demarcated area. When you see this, there are a few things you want to do. You want to assess for peripheral pulses, but never trust your fingers and always use a handheld Doppler. And you can order either ankle brachial index or a toe brachial index if you suspect someone has diabetes and their arteries are non-compressible. The ultimate treatment for arterial ulcers, because these are from lack of oxygen from some kind of thrombus or plaque formation, is some kind of treatment for the artery, whether that is endovascular treatment with a stent or an open surgical treatment like an endarterectomy or bypass. The next category of ulcers are venous ulcers. Now, I've picked out a couple pictures that are easy slam dunks for you. The biggest clue is that there is venous stasis dermatitis. These patients will present to you with dependent edema. In the morning, they will say, you know what, my legs look really beautiful, but by the end of the day, I have really bad leg swelling. There are also people who may have spider veins or large varicose veins that may or may not be painful. And another clue that there is some kind of venous insufficiency is hemosiderin staining. When the red blood cells leak out into the tissue and the hemoglobin breaks down into hemosiderin, it can stain the tissue a dark kind of purplish color. There are two common scenarios in which these ulcers can occur, one of which is minor trauma that leads to a non-healing wound, or because there's so much pressure usually in the leg, there's so much increased hydrostatic pressure that a blister occurs. It's a hydrostatic blister, and that blister can then open up and be a non-healing wound. The reason why these wounds have difficulty healing is something called an MMP, or a matrix metalloproteinase. As the name suggests, it is an enzyme, proteinase, that breaks down proteins. And these MMPs are found in highly inflammatory areas. These leak out from the veins and into the tissues, causing inflammation and ulceration, and make these difficult to heal. If you see one of these and you would like to have a diagnosis of venous insufficiency, then you must order a color flow Doppler or a duplex ultrasound to look for reflux or insufficiency. This study needs to be performed with the patient standing, and the study will always evaluate for a concurrent DVT or deep vein thrombosis. The gold standard of care for venous ulcers is compression. So not only compression, but also exercise and leg elevation. Of all of these, exercise utilizes our own calf pump to help circulate veins, the blood in the veins, and so is the best, but many of our patients are less mobile. And so we rely on leg elevation and compression. The only consideration is when you are ordering compression for these patients who have venous insufficiency, is they may also have peripheral arterial disease, and a significant amount of compression can cause ischemia. And so this is something you would like to evaluate for first. The last category of ulcers that I'm going to go over is diabetic ulcers. Diabetic ulcers are often multifactorial, and as we know, diabetes affects all types of wounds. One of the common ways that someone with diabetes can develop an ulcer is because they have neuropathy and some kind of unrecognized trauma. Diabetes can also form foot deformities like clawing of the toes or Charcot foot, and these can change the way in which we put pressure on our feet. Diabetes causes peripheral vascular disease. These ulcers may also develop depending on the amount of time that you have been diagnosed with diabetes and whether or not the diabetes has been well controlled. And another risk factor for a diabetic ulcer developing is a prior ulcer or amputation. The treatment of diabetic ulcers, besides the gold standard for all of the wounds with wound care, is pressure redistribution. There's something called a total contact cast that allows for redistribution of plantar pressure. It's aimed at decreasing plantar pressure. But in someone who doesn't want to wear a cast from their foot all the way up to their knee, there are other options like sandals with foam or different types of orthotic shoes, or even the knee scooters that you see. So when you are assessing a wound has walked into your clinic and you want to write down in your note exactly what you see and help to dictate what you would treat with. You want to know how long this wound has been there. Is this a very new wound that you have a good chance of helping to heal? Or is this something that's been around for over a month and may be a chronic wound and may indicate the fact that this may be more difficult to heal? What is the location of the wound? The location of the wound can give you a hint as to the etiology, or what is the cause of the wound, whether it be over a bony prominence and you're thinking pressure, or these kind of jagged edged venous leg ulcers, or an arterial ulcer. The location all matters. And then you want to write down the size, the depth, and the shape. When you are measuring a wound, you always start with length, and the length is considered from head to toe. And so you choose the widest length from in the orientation of head to toe. That number is first in centimeters. And then you do the width, so hip to hip width, that's the width, and then the depth. And that allows you to monitor the healing process. And since you know that over a week it should help to contract 0.5 centimeters on average, you can tell if this wound is healing appropriately or not. You want to know and look at the tissue type. So what phase of healing are we in? Is this someone who is in the early stages, in the inflammatory phase? Is there a lot of swelling because that swelling starts early in the inflammatory phase? Is there redness or warmth? This will dictate what kinds of treatment plans you would use and what kinds of dressings. And you want to assess, is there any drainage or exudate? Is there infection that may be present? Do we have to use an antimicrobial? Or has the infection spread and we actually need to use oral antibiotics? You also want to make sure to look at the surrounding skin and the wound edges, because without healthy wound edges and surrounding skin, you will have a difficult time re-epithelializing and having everything bind together. Maceration or wound edges that are too wet will it impair healing? And there are many products that you can apply to the wound edges to help. And then when looking at the wound edges specifically, there is something called epibole, where the wound edges kind of start curling underneath, and so will never help to heal. And those actually need to be debrided away. So to go over wound management, the thing that is most important to you is to know about options for pressure reducing support surfaces. These support surfaces are put into groups and dictated by Medicare. The most commonly ordered are group 1 and group 2, and we'll go over each. So a group 1 surface is either a foam overlay, a gel overlay, or an alternating pressure pad. All of these overlays go on top of a patient's own mattress, or if they have a hospital bed, their own mattress from the hospital bed. These are all ordered in patients who are at risk of having a pressure injury or also already have a stage 1 pressure injury. If you meet someone who is newly bed bound and they don't have any support or surface, then this is the surface that you would want to use. In someone who has a stage 2 or greater pressure injury, and Medicare dictates that it is a stage 2 or greater, either the back, on the sacrum, the buttock, or the hip, then these patients are eligible for a group 2 surface. And what this is instead of an overlay, it is an alternating pressure mattress where you can control whether the mattress is either dynamic or static, and you can control the amount of pressure that this person is experiencing on an alternating basis. The reason why there are dynamic and static selections for these beds, dynamic is what you want to educate your caregivers it should always be on, because you do want always that alternating pressure. If a person is experiencing the dynamic alternating pressure and they are being cleaned or having a sponge bath, it is often difficult as they're moving in the bed from the mattress. And so you can switch it to static so that they have just even pressure along the whole mattress, easier to move the patient around and roll them for cleaning, but always should be changed to dynamic. And then the last one is a group 3 surface, and I honestly have never had to order one of these. These are for stage 3 or stage 4 wounds. It is a specialized bed that has circulated air through these special silicone-coated ceramic beads that aims at creating the characteristics of fluid without this obviously being a waterbed. These group 3 surfaces are often not needed, but can be pursued. If you would like to pursue one of these as someone who is providing the wound care, you would need to write medical necessity as you would for any of the other ones. But this medical necessity has to be updated and submitted to insurance on a monthly basis, including the size of the wound and whether or not the wound is healing. If the wound is not healing, what is your plan to address the wound? And so rather cumbersome to order and oftentimes unnecessary. When it comes to cleaning and debridement, there are, as much of wound care, there aren't very many randomized control trials. There need to be more studies, but the studies that do exist have suggested that while the gold standard for a lot of us is to wash with saline, it may be equivalent to soap and water and may even be equivalent to water. That being said, there is some water that's contaminated by Pseudomonas and you wouldn't want to use. But for the most part, even tap water may be equivalent to soap and water and saline. So whatever it is that your patient has access to, likely is good enough for washing. One of the take homes that I want you to know is that many, many, many of our patients will come in saying that they are washing with hydrogen peroxide, and your response will be to stop. Hydrogen peroxide is caustic to the tissues, and while it does get rid of the bad bacteria, it also gets rid of the good bacteria and should never be used in wound care. And then there's debridement. So debridement is defined by the removal of any kind of dead or necrotic tissue or debris either within the wound or around the wound. And this debris would otherwise impair wound healing and must be removed. There are 3 types of debridement. They are autolytic, enzymatic, and mechanical. Autolytic debridement is our own body's enzymes, utilizing our own body's enzymes to get rid of debris. This is a very commonly used mechanism. We basically support the moisture of a wound and allow our enzymes to do the rest of the work. The next one, enzymatic debridement, is utilizing collagenase. Collagenase, it breaks down, as the name suggests, collagen in the wound. And then mechanical debridement. Mechanical debridement, one example is sharp debridement. Mechanical debridement is often painful and must be done with either topical lidocaine or some kind of pain control before doing it, and some patients can't handle it. All of these different types of debridement are based on expert consensus, and there are no randomized controlled trials to say which one may be better. We do know that there are certain circumstances where you should not debride a wound. Either if you don't know the perfusion status or the patient has a poor perfusion status, you do not want to debride and therefore possibly make the wound bigger. You do not want to debride if it is not consistent with goals of care. Obviously, we do not want to add pain to someone. And you do not debride if there is a stable eschar or scab on the heels or feet, as this likely will not help in healing. The only other time that I did not list here, but there's something called pathergy. So if you debride and you have an extreme reaction, there is a condition called pyoderma gangrenosum. This is one of the conditions in which you do not debride. And then the dressing selection with an ellipsis afterwards. I could go on and on about the various topicals and the things that you could put onto a wound. But the one thing I want you to leave with today is that wounds, you will always be asked, okay, doctor, okay, nurse, okay, should I leave this open to air? And the answer is never. Because as we discussed at the very beginning, our epidermis is the protective layer that keeps everything out and keeps moisture in. And if we have a wound where we have lost our epidermis, we are now vulnerable. So nothing at all should be left open to air. At the very least, wash that thing with soap and water and put Vaseline on it. It should not be open to air. Thank you. If you have any questions, I am happy to answer them at my email. I am currently working on creating a wound care curriculum for medical students, residents, fellows, nurses, social workers, comprehensive thing. And so if that is something that interests you, also please do contact with me. And the last is a question for you. So an 84-year-old male has a past medical history significant for multiple strokes with residual functional quadriplegia. He's newly bedbound and has a home health aide 24/7. That is a good amount of support. And the aide finds an area of non-blanchable erythema on his sacrum. The question is, what kind of support surface should you order for this patient? The options are the alternating pressure pad, a powered pressure reducing mattress, or a donut pillow. And the answer is that APP, that alternating pressure pad. All patients who are bedbound are at risk for pressure injury. And this patient in particular has a stage 1. As we see, he has an area of non-blanchable erythema over a bony prominence. And so we should order a group 1 surface to prevent progression of this wound. So the APP, as mentioned before, is one example. The other examples are gel overlay and foam overlay, and these all sit atop their own mattresses. Thank you very much.